This is WCNY's The Capitol Press Room, and we're joined in the studio by Al Cardillo, President and CEO of the Home Care Association of New York State, which advocates for home and community-based care provided by hundreds of providers and workers. So, Al, I want to start our discussion by fleshing out a point you made in your budget testimony to the state legislature back in February, which was this idea that your sector needed to be looked at more holistically than it is right now. What do you see as the shortcomings of the approach from state policymakers right now?
Thanks so much, first of all, for the opportunity to be here and to discuss these issues. They're really so important, not only in our sector, but really across the healthcare system at this point. So really the issue is that really I would say for the last 10, 15 years, the home and community-based sector has been looked at in a degree of isolated parts. Licensed agencies, managed care plans, fair pay for workers, nursing home transition, consumer-directed home care. And the state has really lost its central focus of home care as a system. So it would be like as if, rather than look at it a hospital as a hospital, you're looking at it in terms of the ED, the obstetric unit, the surgical unit, and never are you coming back to the whole corpus that you have a provider and a system that has to function. Mm-hmm. So the home and community-based system has a very, very a critical set of roles that it plays. It partners with hospitals to ensure that there's transition of very sick patients from hospital to home for a continuation of care. Partners with physicians for those patients that need ambulatory surgery or patients that are getting same-day surgery, cancer surgeries, joint replacements, and then coming home and receiving the services and supports, the surgical wound maintenance, the physical therapy, the nursing care, all of that, again, in a very important partnered way. I think it's well known that home care is very critical for individuals that have long-term disabilities and ongoing needs, and so we play that role very, very critically. But even on the front end, home care is a very important provider for prenatal and maternal patients and even neonatal cases, because it's certainly well established in the state the challenges that we have with the dearth of obstetrical care and prenatal care in areas. Well, home care plays a very important role there as well as end of life.
Well, if I can just interrupt you for a second.
Sure.
You've highlighted how it touches on so many elements of the healthcare system and how it's so integrated with all these other different providers in the system. But do you feel like the approach over the last decade or 15 years, as you've described it, has resulted in, say, unintended consequences? Are we solving for one problem and creating another? And if so, where do you see that happening?
Well, very, very much so. The preamble to the major state law that is governing home care, Article 36, the preamble requires that the state have a central focus of home care as a main pillar of the healthcare delivery system, working with hospitals, again, working with doctors, nursing homes, and other partners. But in the last 15 years, I would say, especially since the Medicaid redesign team of Governor Cuomo, the system was really, the shift in the system was really to look at the managed care plans, which is fine. We have managed care plans in the HCA membership. Excellent plans, but on the service side, the problem is that rather than maintain a look at the system as a system that had to respond to all the needs that I'm saying, the focus really was, again, what remedial action needs to happen here or what supportive action needs to happen there, but without looking at the system globally to say, do we have home health agencies, licensed agencies, hospices? Do we have a set of parts that can work together to perform the roles and functions that the system has? I don't believe that there is a central policy for home care in the state that is currently an agreed upon focus by the legislature or maintained by the executive. Instead, you have different policy actions that are aimed at a part of the system, but then no one bringing it back around. If I can say to you, so the results are right now, when we look at the certified cost reports by managed care plans, by home health agencies, by licensed agencies, by hospices, about 60% are all in negative margins. they're all in negative margins, which basically means that it's costing them more to deliver the services than the revenue that they're really able to obtain. That says a lot about the real lack of a focus. If you look at the budget, the governor has budget proposals that would support the healthcare workforce. Very few, if any of them, also explicitly include home care and hospice as a component. So this is what I'm talking about.
So another area that comes to mind is, as you referenced earlier, the Consumer-Directed Personal Assistance Program, which by now even the least plugged-in listeners may have heard about because it's been all that people talk about in the home care space over the last year plus. But I'm curious, as part of this transition in terms of the administration of that program, we've heard about tens of thousands of people leaving the CDPAP system of care for other modes of home care, and I'm curious what that has meant for your members. Are they able to take on those additional personnel? Is there money to handle those people? Is there a workforce for them?
So that is such a great question. I'd like to respond in a couple of ways to it.
Sure. Quickly, if possible.
Yeah. So
pretend I'm Gary Pretlow with a buzzer ready to go on you.
Okay. All right. So in the first instance, one of the things that occurred is that when the state made rate changes to accommodate what they believed to be efficiencies that they were going to build into the managed care system and the CDPAP system, it did not account for what was then the ultimate shift in something like 80,000 patients from those that had been in CDPAP over more to the traditional system. There are costs in the traditional system because you're paying nurses, you're paying staff as a provider to oversee that level of care.
Sure.
You don't have that in the consumer-directed program. But when the shift occurred, the commensurate adjustment was not made in the premiums to the plans or in the rates to the providers. So it was really a very, very fiscally adverse result for providers and for plans. As I pointed out also in my conversations with the executive, with the state, a patient has a right to be in the consumer-directed program or in traditional care. That right is established by the state. So you can't penalize the patient or the provider because the patient has exercised that choice to move to regulated care. You asked me about personnel. One of the things is that that over the years, the state has really diminished its investment in the kinds of supports for recruitment and training of workers in home care. So as that has diminished, what you have on the other side is patients that need services. So it's almost by default that if the patient is able to find care more quickly by designating their own aid and going into the consumer-directed program, you had the massive increase associated with that without really a commensurate focus on the regulated system, on the traditional system, and what kinds of things do they need to support their care and meet the needs of their community.
So it's no surprise that your legislative priorities and budget requests this year include some of the greatest hits that we hear in the healthcare space, like making rates that are more reflective of what it costs to deliver care. You also want to see some of that money that the governor has touted as savings from the administration changes of CDPAP to go into home care, as well as getting a piece of that what's known as MCO tax that the Hochul administration is implementing right now. And we can talk about money if we get a chance, but on the policy side, is there anything with regards to rules or regulations or statutory language that you're looking for as part of this? Because that's often an easier lift than getting a piece of the pie.
Absolutely. And so talk about workforce for a moment.
Sure.
One of the items of language that we've submitted to the legislature would resurrect a program that expired, I think inadvertently expired a number of years ago, 4 or 5 years ago, but which would allow healthcare providers, hospitals, nursing homes, home care clinics, hospices, to request from the state regulatory flexibility to introduce efficiency in their workflows, the goal of which is to improve the quality of care by having more face time between professionals and patients, to save dollars by having more efficient processes, and also improve the satisfaction of the worker because they're spending more time in what they're there for, which is to care for patients, as opposed to whether it's documentation or other inhibitions. This was a law that was created under a state program called NIFIRM, which was the hospital reimbursement methodology back in the 90s. But that portion of the law continued to exist and continued to thrive. And actually, Senator Kathy Young, when she was the chair of the Rural Commission, sponsored an update to that law. I think it was 2011, 2012, that would allow this law to function without funding, without adjustments, simply giving the ability for hospitals and home care and others to innovate to better meet the needs of the workforce and the patient. So that's one of the things that we put forward.
And what about the money side of things? If you had to have, a favorite child of your proposals, what would be the one thing that you've got to get in this budget, either to stabilize the sector or to maybe make improvements moving forward?
So there's really a twin area that I want to focus on.
Smart move. Way to find a workaround to the question. Twins.
Well, one thing is that home health agencies, which are the agencies that provide skilled nursing, skilled physical therapy, there are patients coming from ICU directly home to these services. Those programs have been closing at an alarming rate. 20% of the state's home health agencies have closed in the last 5 to 6 years. 60% of them are imperiled in terms of their fiscal structure, and we know there's more on the precipice. They have been left out of the budget assistance for the last number of years. There is a program in the public health law, 3615, that was created as a pool, recognizing that as the state was trying to keep people moving through hospitals and keep people out of nursing homes, that home health agencies needed this additional support to meet the needs of the community. And we had asked the legislature to include $100 million from those funds in this particular pool. The other part of the twin is that in the relationship, the joint service between licensed agencies and managed long-term care plans and PACE plans, there needs to be stability in the rates and adequate funding in those rates. The flaw in the methodology is that the statute requires the worker wages to be covered, but does not have a similar statutory requirement related to the operating costs of the agency, what they call the administrative in general. Many of the costs that are in administrative in general are costs that assist the patient with transportation, that help navigate transition of a patient home from hospital, set up appointments with a doctor, communicate with a pharmacist. When there's 30 inches of snow, help the provider navigate those things. So that's missing from the rate structure. And so our proposal is that the statute not only require that there be funding of the wage, but that there also be funding of sufficient operating costs to keep agencies going and to meet the needs. Ergo, that's why one of the reasons you see 60% of them with losses.
Yeah, and those administrative costs aren't going down, so even every year they're not addressed, it just becomes a bigger hole.
Totally so.
Unfortunately, that's all the time we have, though, for this conversation. We've been speaking with Al Cardillo. He's the president and CEO of the Home Care Association of New York State. Al, thank you so much for making the time.
Thank you very, very much. Appreciate it.
Thanks for listening to today's edition of the Capitol Press Room. For an insider take on what's happening in state government, check out our Dispatches from Planet Albany show, available wherever you get podcasts or at capitolpressroom.org.
Join us again for Capitol Press Room, a production of WCNY Connected, Syracuse.